the schools and the parents, so that they don't give their children other foods when they come to school, to be strict about that. It's not working very well, but I think it's going, inshallah, hopefully in the right direction.
So it's very interesting. We've had this discussion about school meals, but the other three speakers have been talking about these strange things like motivational behavior and empathizing with the patient and so on. And I would like to put it to you that here in Kuwait, everything is so crazy that you're trying to help your patients to behave completely abnormally compared with most of society. Is that true?
Yes.
So actually, you're trying to tell everybody they've got to create their own micro-environment and they need to behave differently from their friends and everybody they meet? Is that what you're telling me?
Some people
I'm getting very depressed, you know.
Yes. Some people have a hard time with people close to them, like family and friends that would like go walking with them or eat the right balanced diet with them. But if you encourage them to go and walk, every local area has its
a walking area?
A walking area, and usually it's packed with people. People have been starting to walk now. It's pretty crowded on a daily basis. So.
Well, I think you know what we're trying to achieve as individual practitioners is to try and help individuals who are willing to actually make some changes to their lifestyle. But those changes to lifestyle seem to be compounded by infrastructure, particularly from what I've heard over the last couple of days in terms of the subsidies in relation to food, the transport system. So the infrastructure is against individual change. It makes it more difficult, and particularly where there's a lack of social support, which is very important, because change doesn't happen within the clinical room. Change happens outside the room, and only us as healthcare professionals can support patients and try to empower patients to do that. But when they go outside the room and they're met with a wave of policies and infrastructure that does not support their ideas of making change, then I think that makes it a very inevitable task.
I just have a comment to make. I mean, we are here in Kuwait, we're faced with some circumstances put forward because of the environment, because of the weather. There is lots of barriers to committing to a healthy lifestyle. But I think also people, with their willingness, have found ways, and there are effective ways out there. And talking about the country infrastructure is not really a barrier, because people have developed systems here that works with that infrastructure. For example, people use the malls to walk indoor. She mentioned the walkways provided in each residential area where people actually walk. And there is also the social media where people have developed group to implement physical activity program, dance classes, use the gym. I mean, people are becoming very resourceful. So I don't want Dr. Phillips to leave Kuwait thinking that we're hopeless here. We're not. And we are here in this conference to bring all those brains together and think about ways to help Kuwait and have an optimistic outlook about what all Kuwaitis can do, and us as health professionals to be enablers, to have motivation and not really look at the gloomy side all the time. So that's my comment.
Thank you. I think the only thing I would add to that is trying to evaluate these strategies that you have in place. I think to actually provide some evidence that these initiatives are working and they are making a difference, so that you can grow and develop these projects that will eventually spread out through the social network across Kuwait. So evaluation, I think, is key in terms of looking at the impact that these small areas of work have and the implications that it has and how that can be transferred across to the wider population.
And I would just say as a psychologist that, you know, we're really hardwired to resist change. Change is really tough, and people work really hard to try and make these changes. But I think it goes back to the point that's been made earlier, which is we need to have a culture that supports the change. We need to have policy that supports the change and nudges people in the right direction, so it's easier to do the right things than it is to fall back into the old habits.
Okay, thank you very much. And now we'll break for 30 minutes. We'll be back at 12:30, please. Thank you very much.
Okay, welcome everybody. Now we have the oral presentation. We will have 5 short oral presentations. Every presentation is almost 10 minutes. First presentation will be presented by Dr. Minna Al-Ismaili. She is the head of Community Nutrition Promotion Supervisory. She received her medical degree from Cairo University, and she earned her master degree in human nutrition from London School of Hygiene and Tropical Medicine. She's the coordinator of Kuwait Nutrition Surveillance System, and she's the head of Kuwait Lactation Consultant Association. Her presentation will be about risk factor for overweight and obesity among preschoolers in Kuwait.
Thank you. Children in Kuwait. You know, as you have known now from the beginning of this conference, that the prevalence of childhood obesity has increased at an alarming rate. Even globally in 2011, the number of overweight children were 42 million, which was by the WHO fact sheet. This is an article which is about the public health and nutrition in the Middle East, where the authors have said that in addition to overnutrition, the region is suffering from a double burden of disease with high prevalence of childhood malnutrition depicted by a coexistence of both stunting and obesity among the preschoolers. Also, they have said that undernutrition could also be the result of faulty nutrition practices in early life, whereby evidence has shown that current breastfeeding and complementary feeding practices in the Middle East fall below global recommendations. This is in Kuwait, childhood obesity is a growing health concern, and according to the latest results of the Pediatrics Kuwaiti Nutrition Surveillance System in 2012, the overweight was 6.6, while the obesity was 2.5. Now I'll talk briefly about the PEDS Kuwait Nutrition Surveillance System. It's a child-based nutrition surveillance system that monitors the nutrition status of Kuwaiti infants and young children less than 5. The data are collected with various indicators about stunting, wasting, overweight, anemia, and certain determinants of nutrition and health during childhood. These are collected, the data, by questionnaires completed by the research section nutritionists, and also biological samples are collected. Body mass indices converted to standard deviation scores relative to the WHO Anthro program and SPSS version 21 was used for the analysis. This is the sample size of the Kuwait Nutrition Surveillance System in 2012. As you see, it was around 20,000 total, and highlighted the less than 5 years, 3,860. That sample included 31.8% were less than 1 year, 27.5% were from 1 to 2 years, and 40.7% were 2 to less than 5 years. This is the results of the 2012. And as you see, stunting was 4.3, while the wasting 2.4, and overweight 6.6, and obesity 2.5. And this is a graph showing all the Kuwait 6 governorates. And as you see, the obesity prevalence was highest at the capital, 3.5%, and overweight highest at Ahmadi governorate, 7.7%. And this is showing according to the age group. And you can see that overweight, 11.6% at the age of 1 to 2 years, while the obesity, 4.1% at the age of 4 to less than 5 years. And this is the trends showing 3 years sequence of the data about all age groups and of children, and you can see that it is really increasing yearly. Even the less than 5 in 2002, just 4.9, and now it is 9.1. Childhood obesity is of concern because of the adverse health consequences, and the identification of the risk factors is the key to prevention. The early life environment can determine later risk of obesity, and the risk factors for childhood obesity are not well yet established. Also, the existing prevention strategies, as we heard this morning, focusing on late childhood and adolescence, are largely unsuccessful. That was the base of the study which was done by Professor John Riley, who did publish this study, the early risk factors for obesity in childhood, as a cohort study. And they found that there are 8 factors in the early life were independently associated with obesity at age 7. Also, 8 evidence-based targets for future population-based obesity prevention interventions have been identified. These are the 8 risk factors. The first 4 are for the cohort study, and the rest 4 are for the focus subsample. As you see, the first is the intrauterine and perinatal factors, which include the birth weight was linearly associated with the increased prevalence of obesity. And then the family characteristics, the weight of the parents. If one parent is obese, then the risk is increased, while if both of them, it will be even more. Also, sleep duration. Children with the lowest sleep duration were more likely to be obese. Sedentary behavior, obesity increased linearly as the number of hours of the TV viewing increase. Then the early adiposity or the body mass index rebound before 43 months were independently associated with obesity. Size in the early life with standard deviations at the age of 8 months, 18 months also were significant. The weight gain in infancy and catch-up growth also were significant factors for the childhood obesity. What was not supported by that study, all these indicators, and also it was shown that the dietary pattern is not conclusive evidence of the association. Also, the timing of introduction of the complementary feeding was not significantly related to the risk of obesity, while the maternal smoking, they said it may increase the risk of obesity later in life. There are univariable odds ratios were usually similar to the multivariable odds ratios, except for breastfeeding, which was not significantly associated with obesity in that study because of the multivariable indicators. Breastfeeding may protect against obesity according to Owens et al., which was published in 2005, and there are also other studies about it. This is a study by the University of Illinois, and they have studied the risk factors for overweight obesity in preschoolers as an ecological approach and identified 3 most significant risk factors. Number 1, inadequate sleep. Number 2, parental BMI. And number 3, parental restriction of the child's eating in order to control the weight. Here in Kuwait, as I mentioned, we have the Kuwait Nutrition Surveillance System, and we have certain indicators that we are collecting as information from the parents. For these indicators, we think that these may be the possible risk factors which need further associations. The birth weight is around the mean birth weight 3 kilograms, which was up to 5.2 kilograms in some of the children. And then the breastfeeding initiation or the ever breastfed rate was 81.8%, while the exclusive breastfeeding was 15.2%. For the other children, which are from 2 to 5 years, we have also asked more questions. The timing of the introduction of the weaning food also was not that appropriate for the recommendation by the WHO, which should be at 6 months, and you can see that more than 50% not following that recommendation. Again, the sedentary behavior, for that indicator, we are asking about how much time your child is spending. If it is more than 2 hours a day, then will be included in this number. And as you see, it is very high. 82.6% said that their children are in this sedentary behavior. The physical activity for 1 hour or more is 79%. For that age group is considerable that they are moving around. Then the dietary pattern, we have 2 questions about, are they eating 5 a day fruits and vegetables? Only 18.5% said yes, while consuming or consumption of the juice more than half a cup a day, it was in 68% that they are giving the juice for their children more than the recommended by the AAP. Now, for the management, we should change the lifestyle, modify it, starting with the exclusive breastfeeding as a recommendation for all children, and then the parents changing the diet and the lifestyle. And lastly, which is very important, that mothers should concentrate on to put down the electronic devices for their children and spend more time outside playing, exploring options for physical activity. Now, in conclusion, more joint efforts are necessary for urgent control of obesity problem in Kuwait while dealing with prevention of childhood obesity as a high priority. And then future interventions should focus on environmental changes targeted at relatively short periods in early life, attempting to modify factors in utero, in infancy, in early childhood, which are independently related to later risk of obesity. And thank you very much. How much time?
Exactly, 10 minutes. The second oral presentation will be presented by Dr. Intisar Shabi. She's a pediatrician specialized in nutrition, worked in Food and Nutrition Administration as the head of Nutrition Education Department. She's graduated from Faculty of Medicine in Kuwait. And her presentation will be about Kuwaiti mother perception of their preschool children's weight status.
Assalamu alaikum, bismillah ar-Rahman ar-Rahim. I'm presenting here Kuwaiti mother perception of their preschool children weight status. It's a study, we did it, me and Dr. Nawad Al-Gououd and Mrs. Barsana. She's a clinical dietitian, used to work with us in our administration. Sorry. Okay. Now, as you all of know, that early identification of obesity in children offer the best hope for preventing disease progression with its associated comorbidity. As just now Dr. Amuna mentioned, that the prevalence of overweight and obesity in children, in preschool children less than 5, it's almost 9%. This is Kuwait Nutrition Surveillance System 2012. This figure is as it was shown, it is doubled from year 2002 till 12. Unlike adults, children only partially responsible for their eating habits because they are fed and influenced by their parent or caregiver, especially when they are young. So individual and familial cultural differences in the perception of the appropriate body size and shape, it also goes for the perception of being overweight as a good practice or good feeding, or it's showing that this child or infant is healthy. Usually when we see obese infant or child, we think that he's cute, he's well fed, and the mother is taking care of him. So our study was the first attempt to be done in Kuwait, and our objective was to measure the perception of mothers' weights of their children, preschool children. Our first objective was to assess the accuracy of Kuwaiti mothers' perception of their preschool children weight status, to identify the factors associated with the perceptions, and to find out if the mother have any plans to control the child weight. So we use the same sample that it's used for KNSS. So we took around 500 overweight and obese preschool children to be included in our study with their mothers. We use the same way of anthropometric measurement. However, the weight and the height, it's the same as I said. However, we add the questionnaire for the mothers. Of course, we use the same criteria or definition of the WHO that overweight 85 centile and less than 95, obese more or equal 95. Mother, it's the same underweight, same WHO regulation or classification of obesity that's used. We added the question about do you think your child is overweight, normal, or underweight? And if so, what's your plan for doing that? And this question was added to the questionnaire that the Dr. Mona just mentioned. We use the statistical package for social science, version 16. The level of statistics significant was set at 0.05, and chi-square were tested to assess the association between quantitative variables, and multiple logistic regression was used, and adjusted odds ratios and 95 CL was also used. Now, the results, it astonished us and amazed us. I am sure that it will amaze you what we find. Here for the mothers, usually their range of age 21 to 53 years, and a majority of them between the age of 30 and 39. Children, as we specifically chose 36 to 68 months, male to female ratio 1 to 1.23. 58% of the children were obese. 31% of the sample, they have a positive family history of obesity, as it is mentioned since morning. 37% of mothers have education less than high school education. 38% of the mothers were not working. 50% of the mothers were obese. Only 15% of the mothers were having normal BMI. 83% of mothers incorrectly perceive their children weight status. 88% of males, they were incorrectly perceived, and 79% of females were incorrectly perceived. This means that we still consider having a male is an advantage, and it's not equal. 73% of the obese children were incorrectly perceived, and 97% of overweight children were incorrectly perceived. What's the factor associated with their perception? We check the child age, the mother education, the working status, and the BMI of the mother. It does not, it's not significantly associated with their perception. However, the mother age was strongly associated with wrong perception. If the mother young, as the mother age reduced, her perception becomes more inaccurate. Family history of obesity showed a very strong association with mother's perception of their child weight status. Families with a positive family history of obesities, their perception, incorrect perception is 70%. However, if there is no family history of obesity, it's 90%, which is logic, I think. Mothers' plans to control their child weight. In spite of, we didn't tell the mother that her perception is wrong or right. We ask her, suppose your child is obese or overweight, what's your plan you will do? Whether you will increase the exercise, or change the diet, reduce the intake, or go to a dietitian, or you don't do anything and about it at this age. 2/3 of mothers, in spite of a wrong perception, 2/3 of the mothers have a plan to reduce their child weight. Around 30% of them, they will reduce intake by themselves. 25%, the quarter of them, they will consult a dietitian, and around 13% of them, they will increase the physical activity. 35, or the majority of them, they said we will not have plan, and we don't have plan for our kids. child age and the BMI show a significant association with the mother perception. As the child increase in age, the mother plan is to increase the activity rather than to reduce the weight intake. So they will reduce the weight food intake or dietary intake if the child is young, and if the child is older, around the 5 years, they will increase the activity. Mothers were more likely to have plans for the obese children more than their overweight children. Mothers with a normal BMI were more likely to have a plan, particularly consult a dietitian. Family history of obesity was significantly associated with having a plan to control child weight, particularly by reducing food intake or increasing activity. The 83% of the mothers who accurately perceive their children, they have a plan, their plan of reducing weight is different than the wrongly perceived. Almost 50% of them, they will reduce intake. Around 18% they will consult a dietitian. Almost 50% of them, they'll increase the activity, and few of them, they have no plans for their children. The increased prevalence of overweight has normalized the condition of public mind and contribute to the mother's inability to perceive their own child weight. This is one of the explanations that why mothers perceive their overweight or obese children as normal. Although being obese or overweight is not considered to be a health risk in this age group, there is the early identification and prevention of obesity can avoid obesity and its comorbidities. These are, and one of our limitations that we only ask the mother, we didn't ask the father, or we didn't ask other caregivers of the child, and we didn't ask the mother based on what her perception, if she thinks he is overweight or normal, or why she is thinking that. This was in future plan, our study will include these limitations. Our conclusion, maternal perception of child body weight may have important behavioral impact and health implication. Accurate perception of risk is necessary as a first step to establish behavioral modification goal for diet and physical activity for children health. So the goal can be achieved by getting support and reinforcement from healthcare professionals and families, as well as schools and the community. Since yesterday we are recommending these facts for. We would like to thank all our dietitian and researcher that help us in performing this project. And here, as it's normal, the child is asking his mother, "Mom, am I fat, overweight?" She is answering him, "Not for a fat kid." And this is my son. He is in Queensland, in New Zealand. When I ask him, I'm presenting a lecture about perception. And I told him a lot of mothers, majority of mothers, they don't perceive their overweight child or obese child as obese. He said, "Mom, this is love, and how strong love is." Exactly, because we love our children, we think they are normal and cute and healthy. Thank you very much.
Our third presentation will be presented by Dr. Khulud Al-Yahya. She's an assistant professor at the Science Department, College of Basic Education and Public Authority of Applied Education and Training. She was granted her PhD in Nutrition Science in Department of